Antiphospholipid antibody syndrome Krishna M. Bharati, MD Narothamaredi Ejala, MD, FACP, FASN Basics Description Antiphospholipid antibody syndrome, APS, is a systemic autoantibody-mediated thrombophilic disorder characterized by recurrent arterial or venous thrombosis and/or recurrent fetal loss in the presence of persistent antiphospholipid antibodies, APAs, as evidenced by lupus anticoagulant, LAC, anticardiolipin antibodies, ACL, and/or anti-beta-2 glycoprotein I, GPI, antibody. The APAs enhance clot formation by interacting with phospholipid-binding plasma proteins. The resulting APS can cause morbidity and mortality in both pregnant and non-pregnant individuals. Types of APS, based on clinical presentation: primary, no underlying condition evident; secondary, most commonly associated with autoimmune diseases like systemic lupus erythematosus, SLE. Transient APAs have been linked to certain infections, drugs, and malignancies. Catastrophic APS, CAPS, aka Asherson syndrome, 1%. Most severe form of disease, characterized by thrombotic microangiopathy and associated with multi-organ failure. High mortality if treatment is delayed. Pregnancy considerations: complications include maternal venous thromboembolism, stroke, fetal demise, preeclampsia, and placental insufficiency, fetal growth retardation, miscarriage, and preterm birth. Triple antibody positivity is considered the most noteworthy risk factor. Low-dose aspirin and low molecular weight heparin, LMWH, or unfractionated heparin are the drugs of choice in pregnancy. Prophylactic dose heparin is recommended in the postpartum period, unless patient is on therapeutic anticoagulation, given high risk of thrombosis during this time. With adequate treatment, 70% of patients with APS deliver viable infants. Epidemiology: the prevalence of APAs increases with age but is not necessarily associated with a higher risk of thrombosis. For APS, female-male incidence of APS is around 5 new cases per 100,000 persons per year. In patients with positive APAs without prior risk of thrombosis, the annual incident risk of thrombosis is 0.3%. This risk is increased to 5.3% in those with triple positivity. 10–15% of recurrent abortions are attributable to APS. Prevalence around 40 to 50 cases per 100,000 persons per year. APAs are present in 1–5% of the general population and in 40% of those with SLE. A higher prevalence of 10–15% is seen in those with venous thromboembolism, fetal loss, and stroke. Etiology and pathophysiology: anti-beta-2 GP1 antibodies play a central role in the pathogenesis of APS. The procoagulant effect is mediated by various possible mechanisms: endothelial effects, inhibition of prostacyclin production, and loss of annexin V cellular shield platelet activation resulting in adhesion and aggregation, interference of innate anticoagulant pathways, such as inhibition of protein C, complement activation. Pregnancy-related complications are also a result of autoantibody-mediated effects, interference with expression of trophoblastic adhesion molecules resulting in abnormal placentation and placental thrombosis. Proposed mechanisms: excess production of natural antibodies, molecular mimicry due to infections, exposure of phospholipid antigens during platelet activation, cardiolipin peroxidation, and genetic predisposition. A second hit by environmental factors is often required to manifest APS. Genetics: most cases of APS are acquired. There are a few studies of familial occurrence of ACL and LAC. A valine 247/leucine polymorphism in beta-2 GP1 could be a genetic risk for the presence of anti-beta-2 GP1 antibodies and APS. Risk factors: age greater than 55 years in males, greater than 65 years in females. Cardiovascular risk factors: hypertension, HTN, hyperlipidemia, diabetes, obesity, smoking, combined oral contraceptive use, underlying autoimmune disease, SLE, rheumatoid arthritis, collagen vascular disease, Sjogren syndrome, idiopathic thrombocytopenic purpura, Behçet syndrome, positive APAs surgery, immobilization, pregnancy general prevention risk factor modification, control HTN and diabetes, smoking cessation, avoidance of oral contraceptives in high-risk patients, start thromboprophylaxis in established cases, preconception assessment commonly associated conditions autoimmune diseases, SLE, most common, scleroderma, Sjogren syndrome, dermatomyositis, and rheumatoid arthritis. SLE is the most common autoimmune disease associated with APS. Malignancy infections, viral, bacterial, parasitic, and rickettsial. Certain drugs associated with APA production without increased risk of thrombosis, phenothiazines, hydralazine, procainamide, and phenytoin hemolysis, elevated liver enzymes, and low platelet count in association with pregnancy, HELLP, syndrome. Sneddon syndrome, APS variant syndrome with livedo reticularis, HTN, and stroke. Diagnosis: Saparo criteria, also called Sydney criteria, revised 2006. At least one of the following clinical criteria: vascular thrombosis greater than or equal to 1 clinical episodes of arterial, venous, or small vessel thrombosis, occurring within any tissue or organ and confirmed by unequivocal imaging studies or histopathology without associated inflammation in the vessel wall. Superficial venous thrombosis does not meet the criteria for APS. Complications of pregnancy: any one of the following greater than or equal to 3 consecutive spontaneous abortions before the 10th week of pregnancy, unexplained by maternal/paternal chromosomal abnormalities or maternal anatomic/hormonal causes. Greater than or equal to 1 unexplained deaths of morphologically normal fetuses, documented by ultrasonography or by direct examination, at greater than or equal to 10th week of gestation. Greater than or equal to 1 premature births of morphologically normal newborn babies at less than or equal to 34th week of pregnancy due to severe preeclampsia, eclampsia, or placental insufficiency in the presence of at least one of 3 laboratory findings, confirmed on greater than or equal to 2 occasions at least 12 weeks apart. Lack detected in blood. Anticardiolipin IgG/or IgM antibodies present at moderate or high levels in the blood, greater than 40 GPL or myeloproliferative leukemia virus or 99th percentile, via a standardized enzyme-linked immunosorbent assay, ELISA. Anti-beta-2 GP1 IgG/or IgM antibodies in blood at a titer 99th percentile by standardized ELISA. History of venous thromboembolism or arterial thrombosis, stroke, myocardial infarction, history of recurrent fetal loss or other obstetric complications. Bleeding from thrombocytopenia if severe or acquired factor II deficiency. Personal or family history of autoimmune disease. Physical exam. Signs of venous thrombosis in extremities. Skin manifestations, including a vasculitic rash in the form of palpable purpura or livedo reticularis, superficial thrombophlebitis, or lower extremity ulcers. Livedo reticularis. Cardiac murmurs. Focal neurologic or cognitive deficits. Differential diagnosis. Thrombophilic conditions. Inherited deficiency of protein C, protein S, antithrombin 3, mutation of factor V. Leiden, prothrombin gene mutation. Acquired neoplastic and myeloproliferative disorders, hyperviscosity syndromes, nephrotic syndrome, embolic disease secondary to atrial fibrillation, left ventricle dysfunction, endocarditis, cholesterol emboli. Disseminated intravascular coagulation. Paroxysmal nocturnal hemoglobinuria. Heparin-induced thrombocytopenia. Behçet syndrome. CAPS, hemolytic uremic syndrome, thrombotic thrombocytopenic purpura, or malignant HTN. Diagnostic tests and interpretation. Lupus anticoagulant, LAC, assay an IgG and IgM anticardiolipin antibody, ACL, by ELISA and anti-beta-2 GP1 IgG and IgM antibodies are diagnostic tests of choice. The LAC assay combines at least 2 out of 3 screening tests: prolongation of APTT, dilute Russell Viper venom time DRVVT, and kaolin clotting, with 2 confirmatory tests. A weekly positive LAC result should be considered clinically important. 1. Anti-beta-2 GP1 antibodies are important in the pathogenesis of thrombosis. A positive LAC assay recognizes antibodies against beta-2 GP1 and prothrombin. Although testing for antibodies to phosphatidylserine and prothrombin can help to assess the risk of thrombosis, routine evaluation for prothrombin antibodies is not recommended. The clinical significance of other autoantibodies, annexin V, phosphatidic acid, and phosphatidylinositol, remains unclear. The utility of beta-2-GP1 antidomain I antibodies is being evaluated thoroughly for its diagnostic and risk stratification value. Initial tests, lab, imaging, complete blood count, prothrombin time/international normalized ratio, activated partial thromboplastin time, APTT, LAC, ACL, anti-beta-2-GP1 antibodies. 2. B. Prevalence of APAs and SLE ranges from 11% to 87%, hence, it is important to screen for SLE. Imaging is based on clinical picture, suspected sites of thrombosis, and organ involvement. Follow-up tests and special considerations. The results of LAC are difficult to interpret in patients treated with warfarin. Unfractionated heparin or LMWH and fondaparinux do not affect the LAC assay. Repeat testing at 12 weeks for persistence of APA. Diagnostic procedures/other biopsy of the affected organ system may be necessary to distinguish from vasculitis. Test interpretation. Usual finding is thrombosis and minimal vascular or perivascular inflammation, acute changes, capillary congestion and non-inflammatory fibrin thrombi, chronic changes, ischemic hypoperfusion, atrophy, and fibrosis. Treatment medication. First line. Primary thromboprophylaxis is controversial in patients with APAs and no clinical symptoms. 3. B. Low-dose aspirin or heparin is indicated only in patients with a high risk of thrombosis, as the overall risk of thrombosis is less than 4%. Secondary thromboprophylaxis. All symptomatic, non-pregnant patients with APS need indefinite anticoagulation. The target INR depends on the severity and type of thrombosis. Venous thrombosis. First episode warfarin with target INR of 2.0 to 3.0. 3. B. Arterial thrombosis or recurrent venous thrombosis despite anticoagulation. Warfarin with target INR 3.0 to 4.0. LMWH and fondaparinux are alternatives. Direct oral anticoagulants, DOACs, such as rivaroxaban, apixaban, and dabigatran, all have been approved for treatment of DVT/PE. However, studies in APS are lacking. A prospective randomized trial in 2016 of warfarin versus rivaroxaban in patients with thrombotic APS showed increase in endogenous thrombin potential in patients who switched to rivaroxaban. The 15th International Congress on Antiphospholipid Antibodies Task Force published in 2017 concluded that there is insufficient evidence to recommend DOACs in APS. DOACs may be alternatives to warfarin in patients intolerant to warfarin. Rituximab may be an option in severe cases, possibly in those with thrombotic microangiopathy. 4,5. B. Diniparoid, fondaparinux, and argatroban can be considered in heparin-induced thrombocytopenia. Statins can decrease pro-inflammatory and prothrombotic state in APS but are not recommended in the absence of hyperlipidemia. Hydroxychloroquine can be added in recalcitrant APS. Acalizumab may be useful in refractory cases. Vitamin D deficiency/insufficiency should be corrected in all APA-positive patients, but its role in APS needs further study. Low-dose aspirin is superior to low-dose aspirin with low-dose warfarin due to decreased bleeding risk with no differences in number of thrombosis. 6. CAPS, anticoagulants and high-dose steroids may suffice in less severe cases. Aggressive treatment with either IVIG or plasma exchange is often required in severe cases. These measures have improved survival up to 66%. Treatment in pregnancy. Patients with APAs and no prior thrombotic events should not receive thromboprophylaxis during pregnancy. For women with no prior history of thrombosis and greater than or equal to 2 early miscarriages, treat with either 81 mg ASA alone or in combination with unfractionated heparin, 5,000 to 10,000 USC Q12H, or LMWH, prophylactic dose. In those with a previous late pregnancy loss, greater than 10 weeks gestation, or preterm, 34 weeks, delivery due to severe preeclampsia, a combination of ASA and heparin is recommended. Preconception assessment and treatment with low-dose aspirin, vitamin D, and folate should be offered in selected patients. In those with a history of thrombosis, low-dose ASA plus either therapeutic low-dose heparin, dosed every 8 to 12 hours to maintain mid-interval APTT or factor XA levels, or LMWH, therapeutic dose. Refractory cases, up to 30% of patients have recurrent pregnancy loss despite the use of ASA and heparin. There is no role for warfarin due to risk of teratogenicity. Such cases are best managed in consultation with a maternal-fetal medicine specialist. Surgery/other procedures. Patients with thrombosis may require thrombectomy or an inferior vena cava filter when anticoagulation is contraindicated. Ongoing care follow-up recommendations. Patient monitoring. Standard guidelines for monitoring to maintain INR at therapeutic goal on warfarin therapy. Close monitoring is required during pregnancy. Diet. Hard healthy diet. Patients on warfarin should avoid foods rich in vitamin K, kale, spinach, sprouts, greens. Patient education. Compliance with warfarin therapy to keep INR at goal. Awareness of drug and diet interactions with warfarin. Avoid oral hormonal contraceptives. Prognosis. Pulmonary HTN, neurologic involvement, myocardial ischemia, nephropathy, gangrene of extremities, and CAPS are associated with a worse prognosis. 30% risk of recurrent thrombosis in the absence of adequate anticoagulation. Complications. Pregnancy complications and pulmonary HTN are associated with higher morbidity and mortality. Thrombotic complications are the common cause of death.